Dear audience, let me present my PhD thesis, The Management of Cervical Insufficiency. My name is Leila Tigharghar. I work as a resident doctor at Semmelweis University, Department of Obstetrics and Gynecology, and my vision is to make cervical insufficiency an easily manageable disease by applying the most effective treatment for it. I have two ongoing projects at the moment, and the first one is investigating the efficacy of different therapeutic modalities for cervical insufficiency on the prevention of preterm birth. It's a systematic review and network meta-analysis. Cervical insufficiency is the inability of the uterine cervix to retain a pregnancy in the second trimester, basically an asymptomatic dilation of the cervix. Its incidence is quite low in the general obstetric population, but it can be up to 8% in women with a history of mid-trimester pregnancy loss. Risk factor can include conization of the cervix, inflammation, laceration during birth, or just a structural weakness of the cervical tissue. Despite having such a low incidence rate, it can have serious consequences like preterm birth and mid-trimester pregnancy loss. The treatment for it is quite simple. It's either a pessary, cerclage, or progesterone, and they are easily accessible, but there is no conclusive data on which is the most effective one. So our aim is to compare the effectiveness of these treatments in pregnant women. We investigated the population of pregnant women with cervical insufficiency. We had two subgroups, singleton and twin pregnancies. We compared the three interventions, and we have quite a few outcomes. The primary is spontaneous preterm birth before the 37th week, or fetal death, and some secondary outcomes. We conducted our systematic search in 4 databases, and the search key consisted of population and intervention domain. We started with over 5,000 articles, and in the end, we have 41 eligible full-text RCTs. So my first outcome is spontaneous preterm birth in singletons, and this is the network plot. The dots are interventions, and the lines connecting them are direct trial evidence between them. The size of the dots correlate to the number of patients, and the thickness of the line correlates to the number of studies. And this is the league table. This is a table of estimates containing indirect and direct comparisons. The numbers are odds ratios and confidence intervals. And as you can see, pessary is more effective compared to standard of care in preventing preterm birth in singletons. And for the twins, unfortunately, we couldn't do a network analysis because of the lack of studies, so we used the pairwise comparison, comparing pessary to standard of care or no intervention. Heterogeneity is quite low. The odds ratio is 0.76, but as you can see, the confidence interval does contain the number 1, so we cannot call this statistically significant, but it is clinically quite relevant. And I also have a network plot for preterm birth before the 34th week in singletons. For this outcome, we didn't have any statistically significant outcomes, but we have quite a few clinically relevant ones. Also for the twins, we did a pairwise comparison comparing pessary to standard of care or no intervention. And as you can see, odds ratio is 0.65, and the confidence interval contains the number 1, meaning that it is clinically relevant, but not statistically significant. For fetal death, here is the network plot in singletons, and this is the league table. Here you can also see there is no statistically significant result, but we have also quite a few clinically relevant ones. And for the twins, we also did a pairwise comparison. It's kind of the same situation as previously. It is clinically relevant, meaning that pessary can prevent fetal death in twins compared to standard of care or no intervention. So we have quite a few strengths. We only use RCTs in our analysis, and we have a network meta-analysis with good consistency. We also have quite a few limitations. Some studies use additional treatments. For example, they use cerclage, and they used additional progesterone for 1 or 2 patients. And there was a different time of application for the intervention, but both in the second trimester. And we also have a lack of data for twins in the studies. So our conclusion is that pessary is the most effective treatment in singleton pregnancies with cervical insufficiency. And the implication is that clinicians should use pessary as first-line treatment, but we also need further RCTs to compare pessary, progesterone, and cerclage directly. So I'm working on a manuscript right now, and we plan to submit it this September. And let me tell you a little bit about my second project, which is investigating cervical insufficiency as a risk factor for developing pelvic organ prolapse. Pelvic organ prolapse is the descent of the anterior vaginal wall, the posterior vaginal wall, or the uterus, or some kind of combination of the three. Symptoms can include discomfort, incontinence, or tissue bulging out of the vagina. Risk factors can be mainly obesity, constipation, or vaginal delivery, and the prevalence is quite high. It's up to 40% among women. Treatment can be conservative with the pelvic floor muscle exercises or pessaries, but 11% of women undergo surgeries for it, and a third might need additional surgeries as well. So our aim was to assess cervical insufficiency as a risk factor for subsequent development of pelvic organ prolapse. We investigated the population of Paris women, compared the history of cervical insufficiency to no history of cervical insufficiency, and measured the outcome of the development of the pelvic organ prolapse. And by assessing the risk factors early can facilitate early screening and management and help avoid unnecessary surgeries in the future. And our hypothesis is that a history of cervical insufficiency is associated with an increased risk for developing pelvic organ prolapse. We conducted the search in 3 databases. The search key consisted of population and outcome domain. And the topic is feasible, and we are preparing the Prospero and plan to submit it by the beginning of September. And I've planned to finish my first project by October and the second one by November. And let me thank you for your attention with a quote from Albert Szent-Györgyi: "Research is seeing what everybody else has seen and thinking what nobody else has thought." Thank you.
Thank you very much for the nice presentation. Does anyone in the audience have a question?
Congratulations to your presentation. I got a question regarding your first topic. When we check the outcome, we see that the results are like with very broad confidence interval, crossing the line of no effect. And when we check the network plots, there are like quite a few studies for some outcome. Do you think if you increase the population in future with more studies, that you can see some more mathematically relevant results?
Maybe yes, but we mainly wanted to include RCTs to minimize the confounding factors. There are still like quite many confounding factors, but if we included observational studies as well, I don't think that the results would be quite relevant.
Oh, I agree, but my question is like if we don't see the effect just because we have small sample size, or if we don't see the effect because there is no effect.
Okay, well, we will talk about it in the future, definitely.
Thank you.
Thank you.
I would like to ask you 2 things. First, that did you try to separate the certain time of the pregnancy? Because according to the current guidelines, there's a big difference. Like you cannot do a cerclage at like 23 weeks. Of course, you have to do it much earlier. And like it's interesting to see a comparison like that when I know that that in the different period of the pregnancy, you can use only each one of these methods. Did you try to make a difference with them, or did you try to take it consideration?
We only included articles that used the interventions in the 2nd trimester. So other than that, we couldn't really minimalize it anymore because like there was a lot of different application times. So we excluded all the articles that used like prophylactic cerclage, or they used any kind of treatment in the 3rd trimester. So they're quite heterogeneous in that matter. So,
thank you very much.